Doctor, we are live now.
Hello and welcome everyone for this live webinar show by Glaucoma Society of India. I am Dr. Satyan. On this World Glaucoma Awareness Week, we have multiple programs aligned for the entire week. Today is our day 2. We have 1 hour live program, and this program is called India Wants to Know, an expert panel discussion. This entire show is taken care by none other than by our secretary, Dr. Manish Shah. Yes, completely designed the entire show with a lot of very practical questions for our audience. I wouldn't take much time to welcome all our very experienced panelists for the show today. I will just pass on this mic to Dr. Manish Shah to take over this entire show for next 1 hour program. Over to you, Dr. Manish.
Thank you, Dr. Satyan, for this wonderful opportunity to conduct a question answer session with an expert panel on the event of the World Glaucoma Week. And this is going to be a question answer session where very important practical questions will be put to the experts. And we have the first person who is coming up for the question answers is Dr. Pradeep Vyas, who is a leading glaucoma specialist and a leading light of the Glaucoma Society of India, currently director of Center of Excellence at Indore. And I would like to invite Dr. Vyas first. Welcome, sir.
Thank you, Dr. Manish. Thank you, Satyan, for the opportunity. Thank you, Levin, for the opportunity.
You're welcome, dear.
So we will first start with some important questions. First of all, Dr. Pradeep Vyas, that nowadays there is a lot of discussion on drugs and preservative-free drugs. So do you consider preservative-free drugs as a compulsion for all patients, or do you consider for selected patients, or do you not consider it at all?
Okay, Dr. Manish, it's not possible to not to consider these preservative-free drugs for all the patients. Yes, I do consider preservative-free drugs, but not for all the patients. This is limited for a chosen few patients. So we divide these drugs into three categories. One is the normal drug, and other is the PA-free. So most of the companies they write PF, so that is not preservative free. That is they call patient friendly. And the third category is the totally preservative free, which comes either in the unions or with the Novelia technology or Aptar technology. So unfortunately, to the best of my knowledge, none of the unions are available with any molecules in our country. So most of the drugs which are preservative free are available with the Novelia technology. I uses these drugs for those patients who have a significant amount of dry eye, which we judge either from seeing the condition of the cornea and the lower tear film meniscus and patient symptoms, or by doing some dry eye workup. It says that the lipid layer is deficient or the tear film layer is deficient. So these patients, this subgroup, require the preservative-free drugs.
Thank you, sir. And the second, then we go on to the diagnostic dilemma which all of us face in day-to-day life. You always are screening for glaucoma and looking at the optic disc with a dilated fundus, and you see discs which are suspicious because they have a large cup or they have a neural rim thinning inferiorly, and you want to investigate. So if you do the visual fields and the OCT, and you find that visual field is showing some suspicious areas of depressed sensitivity, sort of fulfilling the Anderson's criteria, but the OCT is completely normal. So how do you go about in this kind of situation? Would you classify it as structural evidence of structural damage, or would you say that it is a doubtful case?
Okay.
And also, if the exact reverse situation where the OCT starts showing some things, but the fields are completely normal.
So let us take this situation like this, that how do we diagnose the glaucoma? So we have to adopt the holistic approach. We have to see the disc, we have to see the fields, and the field should correlate our disc observation. And OCT, yes, nowadays most of us are performing the OCTs, but it is not necessary that OCT would show you the structural defect, because there are lots of problem with the OCTs as well. If you have a patient with the ERM or the patient with the uveitic glaucoma, or if there are medullated nerve fibers, and erroneously you see all green in these patients. So first see the disc, try to correlate with the visual field. If you are not 100% sure, then repeat the visual field. So if there is a reproducibility, exactly at the same place you get the depression on the visual field, like the first field, then yes, you are pretty certain that yes, it's a glaucomatous, and then you can start the treatment for the patient. So the reproducibility of the visual field is very important. And on the other hand, if you get the normal visual field and the OCT shows the abnormality, then first you have to confirm that these abnormalities are real abnormalities or it's a red disease. Most often, with a patient with a high myopia, you get lots of red disease because the axial length is elongated and their RNFL is thin out. So these problems are there, and artifacts. If the floaters are there, and if cataractus changes are there, if corneal scar is there, then you can get the red disease. So again, to diagnose or to treat the patient just on the basis of the superpixel images in the OCT is showing some red disease, either at clock hours or maybe in one quadrant. That does not mean that we should start the treatment. First, we must confirm that the same things are can we visualize with a 90 diopter examination and on the test photograph. If yes, there is a correlation. If there is a very small splinter disc hemorrhage and RNFL splinter RNFL defect, and in the same area, if I am getting the RNFL defect or the red area, the OCT, then yes, there is a case to start the treatment. Otherwise, just wait and watch, and not on the basis of the OCT findings, I would start the treatment for the patient.
Thank you, sir, for a very comprehensive outlook on the subject. And then let's go to the next issue about the treatment of POAG. Recent literature coming out of the UK shows is making a case for POAG being treated initially by SLT. So what are your opinions on that?
Okay, so the first thing, you must do the SLT for your patients with the POAG if you have invested your money into SLT. So obviously you have to recover the money. Otherwise, there are only a few situations where you must do SLT in your patient. First situation, in my opinion, is the pregnant ladies who have a high intraocular pressure and you don't want to take any risk of starting the medication. Second, the patient has a high intraocular pressure with the maximum medical medication. You are not able to control the intraocular pressure. Then you have to take up the patient for surgery, but the patient is not fit to undergo surgery. There are some medical conditions or some other issue. Then, for the meantime, you can do the SLT for these patients. Otherwise, if the patient is a ocular hypertensive, and if you feel that like he's a seller, and he sells from India to Korea, India to Japan for 6 months, and you feel that he won't be able to put the drops, then he is the right case for the SLT. So SLT drop with the SLT is somewhere around 20 to 25% from the baseline, and that too you don't get in all the patients. What our study says that we got the reduction in intraocular pressure by 20% from the baseline in around 80% of the patient, and which remains over there for about 2 years time. And then again, you have to repeat the SLT for the patients to get the same effect. And there is a pretty big number of patients, a good number of cohort, where you don't get the reduction in the IOP with the SLT. So the predictability with the drop or the medication is much better as compared to the predictability of drop in the IOP with the SLT. So SLT is not a first choice of treatment for me with the POAG.
Thank you, sir. Thank you very much. And then in the same situation of POAG, when you come to a situation where your medical control of the target pressure is not sufficient and you think that surgery would be indicated, would MIGS be your first choice? Do you believe that in POAG nowadays, with the new advent of the MIGS options, that your first attempt at surgery should be an MIGS option and consider trabeculectomy as a second entry? And does your entry option change if, depending on patient being phakic or pseudophakic?
Yeah. So for me, still the gold standard remains trabeculectomy. As I said about the SLT, the same thing is true with the MIGS. And with the MIGS as well, the drop in the intraocular pressure is somewhere around 20-25%. It does deliver a good result in the juvenile glaucomas, but I've not seen the great result in the adulthood glaucoma. But some patient, if they demand, then yes, I would consider doing the MIGS. And I'm always more comfortable in the pseudophakic patients rather than the phakic patient. The phakic patient, sometimes find some difficulties and all, so on and so forth. Pseudophakic patients are pretty easy to do the MIGS. The biggest problem, if you are doing the GAT or the bang, then the hyphema gives you a problem in next couple of days following the procedure, because the patient always sees the blur, and patient's expectation is high, and then you are not able to fulfill, then he is always sitting on your head. So I always explain the patient that you have to wait for some time, have a proper appropriate result of the MIGS. But usually in my practice, I try to avoid doing the MIGS and prefer doing the trabeculectomy. That is my first choice of surgery, and then followed by the AGVs. Then comes MIGS.
So thank you very much. And the last question for you is that when you have a situation where your trabeculectomy is not functioning optimally, it is functioning but not optimally, or you are seeing that there is an encystment of the bleb and you contemplate doing a needling procedure. Along with the needling procedure, do you always use an adjunctive antimetabolite? And if so, which one and in what dosage?
Yeah, so as I said that I do more of a trabeculectomy. If I have to do the glaucoma surgeries, then obviously, yes, often I come across and see that the failing bleb or encysted bleb, and then I have to do the needling for the bleb. And now, mostly the 5FU in my practice is gone. I don't think that in last 3-4 years I have given 5FU to any one of my patients. But along with the needling, I always use the mitomycin C in a concentration of 0.04 milligram per ml. That means that the 2 milligram vial diluted with 5 ml of distilled water, and then just draw 0.1 ml of it and add another 0.9 ml of the distilled water, and that inject that along with the needling. So the mitomycin C works pretty well along with the needling. And I also feel more comfortable with that mitomycin C concentration. I have not seen any of the complications related to mitomycin C using along with the needling in this particular concentration.
And how much away from your bleb do you inject?
Usually, I start around 5 millimeter, 3 to 5 millimeter away from the blade, and go within the substance of the blade. And at the end, I always try to go through the deeper ostium and visualize the needle into the entry chamber.
And the antimetabolite you inject in the same incision or
Antimetabolite I inject along with the xylocan at the beginning of the surgery, away from the area through which I am going to enter. So I see the conjunctival mobility as well. It's a nice conjunctival, mobile conjunctiva. Conjunctiva balloons up immediately once you inject the xylocan or the lidocaine along with the metamycin C. It balloons up nicely, and then enter into the blade, little away from the farthest margin of the blade.
Okay, sir. Thank you very much for your insights into all these topics. And now we will move on to our next expert. That is Dr. Madhavdeep Singh, who is a senior glaucoma expert from Delhi and our immediate past secretary of the Glaucoma Society of India. He is head of the glaucoma service at the Ram Manohar Lohia Hospital in New Delhi. Welcome, sir. And we can start with your set of questions for you. And the first one is, how do you advocate using the pachymetry data in glaucoma management in a normal patient as well as a patient who has undergone refractive corneal surgery?
Thank you, Dr. Manish, and thank you, GSI, for this opportunity. See, all the methods of intraocular pressure measurement as available today, they are affected by, the results are affected by the corneal thickness. The extent varies, DCT being the minimum and all others being little more, and all others are non-GAT or more than GAT. So this is how they are affected, and the importance is more in thin corneas and in post-keratorefractive surgeries, where although there are no nomograms, but we do consider them into thin corneas, moderate corneas, and thick corneas, and we do feel that sometimes, and most important thing in glaucoma is that there has to be, things have to match with one another. Like intraocular pressure has to match with the structural findings have to match with the functional findings, and then they have to be, there has to be some asymmetry of the intraocular pressure has to correspond to the asymmetry in the rest of the findings. So this is very, very important. And of course, we do consider a rough guide is 14 microns for 1 millimeters of mercury. It's a rough guideline, although it is not a nomogram. So this is how we consider, and we are definitely more comfortable if the pressure is remaining little high, if the CCT is more. But for thinner CCTs, we are definitely more concerned. And here, one thing which I would like to point out is that in many of the congenital diseases, like in congenital rubella syndrome and some other syndromes, the corneal thickness may be very, very high in pediatric age group, maybe to a tune of 650, 700. And I've seen that patients with 28 pressures or so, 30 pressure, they don't progress at all for many, many years. So this has to be taken care of.
Thank you, sir. Thank you very much. And this 14 millimeters, 1 is applicable even in post-refractive, or it is for the non?
No, it is same. It is same. It is, but not for corneal edema. If the thickness is because of corneal edema, then you tend to measure the pressure recording is lower than what it should be.
Coming to the next question, in this age, when we do a patient's workup for glaucoma, besides gonioscopy, we do perimetry, we do pachymetry, and we do OCT. Most of us are doing OCT today. In this workup, do you feel there is still a place for optic disc photographs routinely?
Absolutely. Optic disc photograph is, I think, more important than anything else. Although its importance is not there in progression. But for the initial diagnosis, I think this is even more important than OCT, because OCT can be unreliable, but photograph is not. And any structural defect which you observe on OCT, if it gives it, if it is associated with some finding on the disc photograph, on the fundus photographs, say a small RNFL defect in the red free photograph, or a small hemorrhage which you missed on the clinical examination, gives you a lot of confidence that you are dealing with a case of glaucoma.
Thank you, sir. That means that we still are doing photographs. Now coming to the next point is that, in your busy clinic, patients are coming routinely for follow-up evaluations for glaucoma. They are already on glaucoma medications, and you have to check all the things that you mentioned. Besides that, now we are also giving importance to OSD. So in your busy clinic, besides all the glaucoma tests, which itself are so time consuming, how do you evaluate for OSD?
See, OSD to me is not something very, very important, because there are two reasons. One is that in case it is clinically significant, then the patient would be symptomatic. If the patient is symptomatic, yes, I do consider its management. But if it is not, then I don't bother much about it. The biggest reason why I bother less about this is that in case a person, see, most of the patients are more than one bottle, glaucoma patients. If the patient is already on multiple bottles and you give another bottle which gives him a soothing effect, the patient tends to stop the anti-glaucoma drugs and tends to continue with the artificial tears, which are very soothing in nature. He says, वो तो सूट नहीं करती, ये सूट करती है. Huh? So the patient comes with this for without having used anti-glaucoma medicine for 1 month, 2 months. So that becomes, a very difficult situation.
Coming to the next question is, what is when you are giving the treatment, what is your limit or what is your formula for maximal medical therapy, MMT?
See, we have to see uh, every individual. We treat human beings, we do not treat glaucoma, we do not treat intraocular pressure. So, this is my concept, that we treat human beings. So, we have to see the routine of the person, the affordability of the person, and suppose if there is a person who is affording and is retired and he has nothing else except to take care of his health, it doesn't matter if you are using 3 bottles, 4 bottles, 5 bottles. But in case there is an active executive who can afford, at the same time he doesn't have time, you have to do early surgery. Similarly, in case there is a person who cannot afford, you see, we get lot of poor patients, because I am working in the government sector. They say कि दवाई दे दो जी, दो है वो दे दो, हैं? नहीं है तो we don't have money. So sometimes we see the patient, we are giving Travoprost for 3 months. Next month, our supply, government supply is not there for Travoprost. We give him Latanoprost. Something will happen. So these are the practical situations that we have to see.
So what is your maximum? But where do you put
Maximum,
limit?
maximum. Mostly, I take it as uh, 4 drugs and 2 bottles. That is the mostly I feel. After that, I advise surgery, but I don't advise surgery in case it's a very, very advanced case. Suppose near total one-eyed patient. Today also we had 2 such patients. I can't take the risk of doing surgery with 0.9 cup in a one-eyed patient. So I will add third, even fourth bottle I do. And I see the prescriptions of most of the glaucoma surgeons who are, specializing in glaucoma and who are sitting in tertiary centers doing this thing. It's not only my belief, although when we are talking, we mostly say after 2 bottles, nothing. But this is not a fact. Everybody is prescribing more than 2 bottles. Maybe it is for their own satisfaction, psychological satisfaction of the treating doctor, but it is true.
Thank you, sir, for a very practical outlook. And one more question for you is that when you are facing a patient who is an angle closure and you have already done an iridotomy and now you are managing the patient medically, For further management, do you consider the parameters of the target pressure exactly the same as you do in open angle, or your threshold for surgery also, is it the same for open angle and angle closure, or is there a difference you consider in angle closure?
Practically, it is the same. It is the same because, but I am more vigilant in angle closure glaucomas because they are more likely to fail with the medical therapy, they are more likely to fail with the surgical therapy also. So, in case there is an early cataract, I have, I would like to operate cataract surgery early, especially in case there are not much synechia. If there are 360-degree synechia, there is no point. There are 270-degree synechia, there are no point in doing cataract surgery. It is not going to help. But in case there are early synechia, then cataract surgery, in case there is a presence of cataract, then surgery is advised early. And otherwise, I follow them little more frequently than a stable glaucoma, open angle glaucoma. I call them 6 monthly or so. But a stable angle closure glaucoma, I would like to see them every 4 months.
Thank you, sir, for your valuable insights onto the subjects. And we will move on now to our next expert, Dr. Vinay Gupta, who is also from Delhi at the All India Institute of Medical Sciences in the glaucoma unit. Welcome, Dr. Vinay, and I hope you are ready for the questions. The first question is that in angle closure scenario, we classify the angle closure based on the gonioscopic findings into angle closure suspect, primary angle closure, and angle closure glaucoma. So once you see a patient whom you have classified as angle closure, do you always advise a PI to all such patients, or you have some other factors you consider?
So I think you mean angle closure suspects, or do you mean a PAC?
I mean a PSC.
So the iridotomy, the only thing an iridotomy does is to relieve a pupillary block. It doesn't do anything more than that. So the most important thing is to identify if there's a pupillary block. If there's no pupillary block, there's no point in doing an iridotomy. If the lens is the cause of the angle closure, the iridotomy is not going to push back the lens. The iridotomy is not going to thin out a thick uveal tissue. The iridotomy is not going to flatten a plateau iris. So you understand what I'm trying to say is that we do not do iridotomy right, left, and center. We do it only once we've identified that the pupillary block is the primary mechanism of the angle closure for which the patient is going to benefit with an iridotomy. So this whole thing of doing iridotomy in every patient, I think, is not correct.
And how do you go about ascertaining the angle closure is due to pupillary block?
So all you need to do is to make a slit. And you can even show your resident from outside. The slit will mimic a pupillary block. That slit will show you the pupillary block. So a thick lens will cause the whole iris lens diaphragm to move anteriorly. Whereas a pupillary block can be seen just on a slit lamp examination. You don't even need to put a gonioscope there.
So thank you. I know you had written one fantastic article, review article, editorial in the IGO and on the iridotomies. The coming to the next question is that the burning topic today is about MIGS. So what are your criteria today for advising MIGS in an open angle situation?
Yeah, so for an open angle, the kind of MIGS that are available in our country are primarily, the gonio surgeries. And we do not have too many devices, unfortunately. The only device currently available is the eye stent. We've done a few eye stents, and frankly, the IOP reduction was not too great. So given the cost of the device, we have really not gone in much for those devices. But as far as the surgical procedures are concerned, which is bang, or you can do a KDB, or you can do a GAT. I think we have started doing these in a big way. And if you ask me what is the criteria for advising these in patients, you have to counsel the patient, because as it was previously said, that these procedures can cause hyphema. So if your patient has been counseled well before, there is a big chance that these procedures, sparing the conjunctiva, can bring down the intraocular pressure dramatically. And we've published a lot of these articles on GAT as in different types of glaucomas, right from mild, moderate, even advanced glaucomas. We have shown that these angle surgeries really can do well, and not just for open angle glaucomas, but even for angle closure glaucomas, the angle surgeries have. So because we are in a tertiary center, in a academic center, so we can take the liberty of doing these procedures in a large group of patients. Of course, the patients have hyphema. There is a very high incidence of hyphema with these procedures. But then if patient is counseled well, everything goes fine. I mean, almost like 95% of these hyphemas resolve on their own. I mean, it's only about 5% that we have had to drain. But basically, I think they're fantastic procedures.
So, coming to the same point, so when you counsel the patient, so you're coming, as the question was put earlier to another expert, was when the patient is for an open angle and requires a surgical intervention, your first choice will be a MIGS procedure before you do a trab. Is it so in your situation today?
There are certain situations where the MIGS will not work. There are certain situations, for example, traumatic glaucomas, it doesn't really work. The angle surgeries don't work. The angle is totally scarred. So the whole meshwork is actually pretty scarred and they don't work. And we've also shown that if you do a 360 GAT compared to 180 GAT, the success rates are much higher. Unfortunately, the success rates are not very good with traumatic glaucoma. But basically, if given a choice, I mean, I would always consider to do a conjunctival sparing procedure as my first go. So yes, so doing a GAT would be a choice which I would prefer even over doing a bang or a KDB. You either do a bang which is like 360 degrees, which is more difficult to do. But these days with the suture assisted GAT, it becomes much easier and much faster. Actually, now it is much faster than doing a trabeculectomy also. So in a way, the surgical time is also much less for glaucoma surgeries. So yes, I mean, once the patient is counseled well, the go-to procedures are conjunctival sparing. Yes.
So as far as the counseling point, which is very important from what you say, what are the important points in the counseling you cover? So one is the hyphema and the expectation that vision will be affected for some time. Besides that, how do you handle the expectations as far as pressure reduction is concerned? Do you promise them a good pressure reduction or do you say it's variable?
Yeah, I mean, you see, in glaucoma surgeries, I mean, no surgery you can promise that the pressure reduction will be like very great. I mean, in trabeculectomy also will fail over a period of time. But a trabeculectomy failing vis-a-vis a GAT failing, this is the how you have to put it to the patient. If a trabeculectomy fails, the choices are remain limited. On the contrary, if GAT fails, you can still have a clean conjunctiva to do a surgery later on. So, I mean, the kind of counseling we do is that we are going to do a small procedure. Let us hope that it works well and your IOP comes down. If not, then there's always a chance that we can do a trabeculectomy again. But if a trabeculectomy is already done, then and if it fails, then of course there are more difficult chances. You are left with lesser chances. So, I mean, this is how I would counsel the patient. But yes, again, I would say that a GAT, a 360-degree GAT really helps.
So your preference, the next question is about the mixed, your experience of the techniques, and from what you say is that your first choice is a 360-degree suture GAT as compared to a bang or a KDB.
Yes.
And eye
Yes.
stents, you are not very happy with the results.
No.
Okay. So then coming to another topic completely, in pediatric glaucoma, we know that the primary approach is to do surgery. And once a surgery has been done, then we are following the patient closely and we find that IOPs are not well controlled. So what, besides medications, do you consider any other options?
Well, we do tide over with medications to a large extent. If the IOP can get controlled after surgery with medications, so we try to control them because you see, the child has a very long life to live. The more surgeries you do, the more conjunctiva you are destroying over a period of time. So we try to tide it over as much as possible with medical therapy. But then if it doesn't, then of course you have to do surgery. I still do one trab, I do another trab. And in a child, putting in a tube would always be a last resort. I mean, I've had children following up for more than 15, 20 years. I've done one trap, I've done a second trap, I've done a third trap, and finally I had to do a tube. So yes. So as time goes by, these procedures do tend to fail, and you may have to do repeat surgeries, and this is how you have to go. So you have to be available. I mean, you have all these surgeries will have to be available for you to tide over the life of that child. Yeah.
Okay, so thank you very much, Dr. Vinay, for very insightful into the subject, and we really appreciate. Thank you very much. And now we can move on to our next expert, who is Dr. Mayuri Khamar, who is from Ahmedabad, and now she is working at the Ocura Eye Center in Ahmedabad. So welcome, Dr. Mayuri.
Thank
And she
you.
has been in the GSI for a long time and been the treasurer as well. So your question would be, the first is that we know that normal tension glaucoma is a situation we diagnosed by exclusion. We exclude other things and do many tests to exclude. So before you label a person as a normal tension glaucoma, we do non-ophthalmic tests as well. So do you think that in every patient who has a normal tension glaucoma kind of scenario, a neuroimaging and a carotid Doppler or a carotid flow study is mandatory?
Yes. Before I start, I would like to thank Satyan, Manish, and GSI for giving me this opportunity. In NTG cases, as you correctly said, it should be diagnosed after excluding all other conditions. So non-ophthalmic conditions that I always ask for in investigation is MRI. Then MRI is angio, which is also very important to rule out the vascular insufficiency. Then carotid Doppler and ophthalmic artery Doppler also I ask for. Then ocular perfusion pressure, if it is less or low, then also it can affect. Again, systemic diseases, if they are there, they can cause some of the vascular defects. So I also ask for the lipid profile, and if there is a high viscosity, then platelet counts. This all will give me some idea whether I am dealing with a genuine glaucoma or something other than that. Then apnea, sleep apnea study, which is also available, that also I can ask for. So these are some of the list which I always look at before diagnosing this case as a NTG cases. Ophthalmic causes could be burned out glaucoma, past history of use of steroid, or some trauma. So those are from history you can take these exclusions.
So my point is that even you find a situation where you are suspecting normal tension glaucoma, do you always do all the studies or are you selective?
I always look at the patient as a whole. So looking at that systemic disorders or some history, then from visual field test, that also will give you some clues. If it is neurological, you can have a vertical defects. So that can also be correlated. So this all will complete the diagnosis.
Thank you very much. So when you start treating these patients, do you treat all the patients you suspect normal tension, because you don't know which one is going to be responsive to pressure and which one is not, or again you have some kind of a system where you select the cases?
Usually I don't start the treatment in all these patients. If it is not an advanced defect, I just do the observation. The visual field I repeat after 6 months. And of course, diurnal variation has to be taken care of. So if there is any fluctuation in that, or patient has some other systemic condition coming up in between, that also will increase my suspicion to start the treatment. Otherwise, I will just wait for 6 months. I don't start treatment in all.
Thank you. And when you treat, what is the choice? Which are the drugs that you have choose and would you like, and which one are the ones you would like to definitely avoid?
PG analog is my first choice because the reduction in intraocular pressure is compared to the other is 25 to 30%. Secondly, it can lower the intraocular pressure lower than the episcleral venous pressure. Other drugs though are okay, but Netasodil is also supposed to decrease the intraocular pressure less than episcleral venous pressure. So that could be another choice of the drug. I will like to avoid beta blockers, which may cause the hypotension. So in those, at least I will not start with the beta blockers in such cases. Carbonic anhydrase inhibitor can be of a use because it also increases the microcirculation of the optic nerve head. So that may help in these anti-G cases.
Now coming to the next case, next scenario is that when you do trabeculectomies for any of the indications of glaucoma, do you always use antimetabolites? And if
Yes.
you use the antimetabolites, do you use the sponges, or now many are now converting to injectables? What are you
No, still, I am the old-fashioned person. I do use antimetabolites, mitomycin C, in all my trabeculectomy cases, and I use sponges. And variation, like time period, depends on the severity and the type of patient that I am operating upon. But most of the time, it is 200 microgram for the 2 minutes. I'm not injecting it.
Why do you think the injecting system? Do you have any personal choice, personal reason?
Can
or
you just
because
repeat
you have
it?
been doing?
Can you please repeat it?
So when in the injections which people are using, why you have not adopted?
I have not adopted because I am getting good results with whatever technique I am using. That's why I have yet not adopted that. Because the injection usually to be given 20 minutes prior to the surgery, and my patient is out of OT, I do multiple surgeries in a day. So every time you cannot go out and do the injection and then come back, and so maybe this is
Practical.
more comfortable.
Yes. Now coming to the next question is that we already had a discussion a little bit on angle closure. And always this doubt has been there about where the lens plays a role, and Dr. Vinay also gave his opinion. What is your opinion of the role of lens extraction in what scenarios of angle closure? And do you have a system of deciding how to take?
Yes. Clear lens extraction, I will never recommend. Unless you have as Vinay has already pointed out, you have a bulky lens or a very high lens vault, and there is a typical pupillary block iris configuration. In those cases, or when there is a significant cataract, primary angle closure suspect, or the primary angle closure where the angle oppositional closure or cynical closure is 180 degree or little more. In those cases, the lens removal will be of a help because it increases the anterior chamber depth as well as open up the antechamber angle. And visual rehabilitation is faster. The drug requirement could be little, you can have a less number of drug requirement compared to the what patient had before lens surgery.
Can I say something here?
Yes, please.
See, if the anterior chamber depth is 2 millimeters, if the patient is 40 years old and the IOP is 40 millimeters of mercury, what are you going to do?
The laser PI is already been done?
No, you have to remove the clear lens. The iridotomy is not going to deepen that anterior chamber.
No, but what is the lens fault you said?
The lens vault could be, I mean, anything. Assuming that the lens is thick, let's assume that the lens vault is 700 microns. Let's assume that the lens is 5 millimeters.
I think
To
let's
say
come back. Let's finish the question. Then there is a little time for interaction between the experts. And I think we'll keep this topic for that. Vinay, sorry to interrupt you. And we'll come back to this topic for certain. So I would like to thank Dr. Mayuri for her inputs and move on to the last expert. That is Dr. Purvi Bhagat, who is a professor and leading glaucoma expert at the MNJ Institute of Ophthalmology at the Civil Hospital in Ahmedabad. And welcome, Dr. Purvi.
Thank you, Dr. Manish. Yeah.
I would like to start your questions with the situation of ocular hypertensives. And which of the ocular hypertensives would you like treating, or would you treat all of them? And how do you decide on the target?
I'm thankful to Dr. Satyan, Dr. Tuli sir, and you for inviting me for this expert panel discussion. So ocular hypertensives are always challenging cases to manage, to diagnose, and also to decide the mode of treatment. Since the study was done, which has been years back, the OAT study, which we so popularly quote, because now things have been changing since so many years. Since then, a few factors have been identified which put the patient at a higher risk for progression of glaucoma. So these being the age of the patient, like of course we know that higher the age, higher is the risk for conversion. So that is something we need to keep in mind. Second is the baseline intraocular pressure. Again, higher the IOP that you see the patient at, then you would be tempted to treat. And usually that range is somewhat around 25 to 28 millimeters of mercury measured with the applanation tonometer. The third would be the central corneal thickness, which Dr. Manavdeep Singh sir has elaborated on. So if these are thinner corneas, they are more at chances of progression into open angle glaucoma. So these are again where my treatment for threshold will be lower and I would be tempted to treat them earlier. And of course, the disc findings. So vertical CD ratio or any other suspicious findings, if you see in the disc, then I would be tempted to treat them earlier. So, and according to the study also, it has been said that higher the number of risk factors, then the decision to treat is more favorable. And there is something also which was not done in the study, but which we very strongly believe clinically is the family history. So if there is a family history of primary open angle glaucoma, or maybe there is a visual handicap, surgeries done in the family because of glaucoma, then of course I would like to start treatment in these cases much earlier. And having said that, of course, if the risks are much lower, then there is a very delicate balance between deciding to treat and not treat. Then of course it becomes a shared decision between the patient and ourselves, that we need to explain to the patient that you are at a risk, but the risk is very less because maybe you just have one risk factor or two risk factors. So if they are educated enough, they are likely to stay under follow up and come regularly for the scheduled visits, then maybe yes, we can just observe and monitor. But if we feel after the communication with the patient that they are not likely to come for follow-up, or they are more skeptical about missing out appointments, then we might as well treat the patient. Because if you don't treat, then they tend to take it very casually that, oh, I don't have anything to worry about, they are not treating me. If you put the patient on treatment, so they are a little more concerned and they tend to be, more closely adherent. And talking of the target IOP, yes, this is somewhat it's say 20% from the baseline intraocular pressure that we have seen the patient on.
Thank you, Dr. Purvi. And also coming, do you consider MIG for OHTS patients? Now, if an OHTS patient comes with a cataract, for example, and is anyway going to do a cataract surgery, angle is nice and open, would you advise a MIGS procedure along with it?
No, see, in the first question, we were still debating on whether to treat the OHTS patient or not. So right away, going for a surgery in these patients is a strict no from my end. So but if it's a simple cataract, then I would do a cataract surgery in the OHTS patient. If the cataract can wait, then monitor the OHTS or maybe medically treat. But MIGS is a strict no as of now, as of today.
And what about the SLT in the same situation? Would you, if the patient is averse to putting drops, would you consider SLT as it is not invasive actually?
Yeah, yes, SLT we do frequently in these patients, and now I think there is enough evidence about the SLT trials. The light trial was there, the ghost trial was there, and it has been found that it is quite effective in reducing the intraocular pressures. It works as good as one PG analog. And as you mentioned early on in this meeting, that the UK also, they have now accepted as SLT as the first line of treatment for ocular hypertensives and even primary open angle glaucoma. And even the European Glaucoma Society guidelines, American Academy, all of them have now accepted it as the first line of treatment for ocular hypertension and for POAG. So the advantages are many, and in fact now they are also moving on to the low pressure, the low energy maintenance type of an SLT. That is, rather than doing a 360-degree full energy as required, the champagne type of bubbles that we keep seeing. Now they are attempting to do a lower energy type of an annual maintenance repetitive SLT, which is being found to be useful. So SLT, yes, being non-invasive is definitely an option to be considered.
Now going to the other extreme of the spectrum of glaucoma, when you decide to do aqueous drainage devices, what are your preferences? Do you go for the valved ones or do you go for the non-valved? Or how do you choose and which ones do you prefer?
I think now it's a known fact that we can actually answer this question in one statement, that if you want an immediate or an early IOP lowering, you need to go for the valve devices. But if you want a delayed IOP lowering is okay with, the patient is willing to continue with the meds for some time, but you are looking for a good long time survival, then the non-valves are to be considered. So that I think sums it up in one statement.
So
And
you-
I personally, yes, I have been using the emerged glaucoma valve for a long time, but now considering its cost, it is like going out of the prescription range, and now we are exploring the other options that are there.
And then coming in again, then you are treating an open angle patient. So before you advise a trabeculectomy, when there is a stage threshold for surgery, so what is your threshold? Do you usually exhaust a full range of medical treatment before you advise surgery, or you go in earlier?
Yeah, this also has been partly answered by Dr. Manavdeep Singh sir, that right now the range of drugs that are available are huge. So if we talk of MMT, actually it amounts to about 5 to 6 drugs. So the first questions would be, is the patient going to afford all the drugs, talking of MMT? Is the patient going to be compliant with so many bottles and so many drugs? Are there not going to be any side effects with any of the drugs that we are going to prescribe? So automatically, if we answer these questions, the role of MMT as such does not stand in place, because this is not going to happen with all the patients all the time. There may be very few who may go up to that stage. So the threshold for going for a surgery and stopping at, maybe, as sir said, just 2 bottles. So either it is one dual fixed dose combination in one bottle and dual fixed dose combination in another bottle, or it could be 3 drugs in one bottle and 1 drug in another bottle. So that is kind of the optimum, because all of these drugs, if we see, sooner or later they do affect the ocular surface. All of them are notorious for causing hyperemias, conjunctivitis, dermatitis. So in fact, by unnecessarily putting on the medication load on the patient's ocular surface, we are actually adding a risk factor for failure. So we would rather avoid doing that and plan for a surgery much sooner than, building up the therapies and then getting the ocular surface very unhealthy and then again risking failure of surgery.
Thank you, Dr. Purvi. And now that we have finished all the experts and the questions, I think that we can come back to the question which Dr. Vinay wanted to elaborate. So Dr. Vinay, you were saying about the lens extraction role in angle closure, and I would like to ask you to speak on that.
Yeah, my take on this is that clear lens extraction is not such a bad word. I mean, if the lens is the culprit, then I don't think the iridotomy is going to work. I mean, the iridotomy is not going to push back the lens. If the lens is thick, if the lens vault is increased, if the anterior chamber depth is 2 millimeters, what is the iridotomy going to do? Nothing. You have to get that lens out, whether it's a primary angle closure suspect, whether it's a primary closure, whether it is primary angle closure glaucoma. I mean, you may have to do a clear lens extraction to prevent that patient from going blind. To say that clear lens extraction is a no. I don't know how this thing has come about at all. If the lens is the culprit, it has to come out, whether it's cataractus or whether it's clear, it has to come out.
My question to you is that, we don't have clear guidelines of anterior segment OCT cutoffs for lens thickness, lens vault, and anterior chamber depths, where we should clearly say that this is a case for a lens extraction, clear or otherwise. That is the doubt that is there in the mind of a lot of people today. So what are your criteria? How do you decide? You have any cutoffs?
I look at the anterior chamber depth. If the anterior chamber depth is less than 2.4 millimeters, then it is a very strong case of doing a lens extraction. And this is published by in the JAMA Ophthalmology, where they have used biometric parameters and have shown that a lens extraction, whether it is cataractous or clear, definitely benefits if the anterior chamber depth is less than 2 point. I mean, this is what I have got from that article, which was published almost like 10 to 15 years ago. So to say that, we do not have criteria, I mean, we can always build our own criteria, but I mean, it stands to logic that if the lens is a culprit, I mean, there is no point in doing anything else. What are you going to do? What are you going to do a trabeculectomy in a patient with 40 pressures and an anterior chamber depth of 2 millimeters?
So thank you very much for that important insight, because otherwise we are all carried away only on doing iridotomies. So we have to look at all the parameters, and there may be some gray areas. So we should work on developing our own criteria. Thank you very much. And I would like to invite any one of the panelists or experts here who would like to take up any topic which has been discussed and elaborate any more points.
Dr. Manish, I would like to, add one more topic which has been left out,
Yes.
and that is the issue of tachyphylaxis.
Yes.
And we all need to remember that many of these drugs, rather most of these drugs, become less effective over a period of time. And the most notoriously known for this are the beta blockers. So when we are adding a fourth or a fifth drug in a patient who has been stable over last few years, we should, before adding another drug, we should try to see in case we can exchange a drug rather than adding another drug. So because tachyphylaxis should not be forgotten, which most of us do forget.
Yes, that's an important point, and I'm glad you brought it up. Anybody else would like to clarify some more points? I was most welcome. We have a few minutes more.
I mean, I can.
Can I talk on SLT?
Yes.
I have done a lot of SLT, and I have seen that it works very good in the virgin eyes, which eyes are not been treated before. And it is good for the ocular hypertension, as Purvi has already said. We have seen good result with the ocular hypertensive who needs treatment. Instead of giving drops, SLT gives good result. And in my cases, the patients juvenile opening a glaucoma or the young patients, there the SLT is not working good. So no point in very young patients.
Yes.
Actually, we have studied why the SLT doesn't work in some patients and why it works in some patients. So if you put in a gonioscope and you look at angle dysgenesis, either on goniophotography or you look on ASOCT, and you find that there is dysgenesis, the chances that the SLT work are very poor. On the contrary, if you see a normal looking angle on gonioscopy, and now of course you can even do a high definition ASOCT, and you look that there is no dysgenesis, the chances are that the SLT will work. So we published this where you can look at predictors of the success of SLT, both on gonioscopy as well as on ASOCT.
Thank you for that insight. Yes, any other comments I would like to invite? Still, we have a minute more.
Yeah. Can I, Dr. Manish?
Yes, please.
Yeah, I just wanted to elaborate on the subtenance mitomycin that you were talking of. I have practically now switched over to subtenance mitomycin in the trabeculectomies. So what we have found is, and this has been given as a thesis also, and now another student is studying the long-term results. So the blebs are much more diffuse, and the posterior diffuse mildly elevated blebs that we are looking for, and it's much more predictable, because with the sponge the amount of absorption that occurs, the soaking that has occurred, it is evident that it is little unpredictable. So this gives a more controlled delivery of the drug in the area that we are looking for. And I think when it started, it was that you had to give it in the preoperative area and then wait for half an hour and then take the patient into the OT. But now the technique has changed, that after the aseptic precautions are done, painting and dripping is done, the first thing that you do is you inject the mitomycin C, about 7 to 8 millimeters posterior to the limbus. and then you just milk it, diffuse it all around in that area where you want the bleb to happen. So, and then you proceed with the vicryl or fixation suture, whatever you're taking. So we need not actually wait for that entire preoperative period. It has now become one of the steps of the conventional trabeculectomy. It is just the first step, and then you proceed with the traction suture. So
Dr.
that was
Manish,
just my input.
I have also switched over similarly with a similar technique as Dr. Purvi.
And what dose concentrations are being injected?
It's 0.02% and just 0.1 ml using a tuberculin syringe.
The
The
dose
important thing is, yeah, important. Sorry, sir. Yeah.
The dose is 20 micrograms, whether you give it in 0.1 or 0.4 or millimeters, because I give it in 0.4 ml because then you can diffuse it to a much wider area.
The trick here is, yes, you have to diffuse it after you have injected, not just leave it as a bolus in that area. That milking in that area has to be done.
It has to be diffused, and the dose is 20 micron.
Thank you very much, all the panelists, for a very, very insightful of all this, sharing your experience of so many years in small nuggets of wisdom. And I would like to thank each one of you and Dr. Satyan for giving this opportunity and spreading the knowledge in the World Glaucoma Week. Thank you very much.
Thank you,
Thank you very much.
Dr. Satyan, and thank
Thank
you.
Thank you all so
Thank
much
you.
for being there today on this World Glaucoma Week awareness program. And I really take this opportunity to thank our dear Secretary Manish for conducting such a great show. I am sure that this will be really useful for everybody. And this is available in the YouTube channel of our GSI. Please, all of you can watch. Whoever has missed today, you can watch later also. Thank you so much, and we'll connect you tomorrow by same time, 8 p.m. Tomorrow we have our presidential talk by Dr. Vinay Nangia and our Dr. A.L. Vijaya Madam. Both of them are there tomorrow. So, in your digital devices tomorrow at 8 p.m. Thank you all and good night.
Thank you.
you.
Thank
Thank
you.
you. Thank you all. Thank you.